Hello, everyone. I think we're going to make a start now. Apologies, we've started about 8 minutes late, and it's going to be quite a short meeting, so we'll get going now. I'd like to begin by welcoming everyone to this meeting of the joint Cambridgeshire and Peterborough Health and Wellbeing Board and Integrated Care Partnership at New Shire Hall. We are the committee in common of these two organizations. Filming and photography are allowed at this meeting, so please feel free to take pictures and use social media during the meeting. Can I ask, though, that everyone present turns their mobile phones to silent or vibrate whilst the meeting is taking place? Please be aware that this meeting is being live streamed and that a recording of the meeting will be available to view on the County Council's website. There is no fire alarm test scheduled for today, so if the alarm sounds, please leave by the nearest marked fire exit and assemble in the car park. The closest fire escape is through the middle doors on my left, past the water closet and kitchen. I think we'll take very quickly apologies for absence. Naomi, would you like to report absences, please, or apologies?
All right, thank you. Thank you, Chair. Absences today, we have apologies from John Thomas, from Professor Steve Barnett, Dara Preston, Councillor Katie Coe, Paul Med, Rob Bridge, Jackie McGeechee, John Gregg, and Martin Bruning. Thank you.
Thank you. Rather than go through a long roll call, I think we'll just note everyone who is here and put that into our minutes. And then we will move next to any declarations of disclosable pecuniary interest or non-statutory disclosable interest. No? Okay. Thank you. And next, we are being asked to approve the minutes of this meeting on the 22nd of March, 2024 as an accurate record. All okay with that? Yes, good. Thank you. Then I'd just like to check, actually, I think this room is booked for 1:30. Is that correct, for another meeting? Do we have to move out of this room? No. Okay. Well, we're not planning to make it a long meeting, but I'm just aware we've started late and we will have at least one AOB. I think I'd just like, before we go to our first substantial item, I'd just like to acknowledge that in this room this morning, we've had a really excellent development session. We have basically given ourselves a big kick up the backside and said we agree on our analysis of our challenges. We are a combined health and wellbeing board and integrated care partnership. We are responsible for place-based working. And we have, I think we've agreed that when we get to our agenda planning, we're going to need to bring that as action to this formal meeting and to do that on an urgent basis. So I'm just state that for the record, and that will be, we will get to that in the agenda. Our next item is the Better Care Fund 2023-24 end of year report. May I ask Caroline Townsend, Lisa Murray, and Sandra Pedley to present this item? Thank you.
Thank you. I'll give a high-level overview. I'm conscious we haven't got very long meetings. So the 23-24 year-end returns, which we require to submit to NHS England for both Cambridgeshire and Peterborough, they cover a number of key areas. Predominantly, they provide an update in terms of our performance and how we have performed against the national metrics. They also confirm our income and expenditure plans in terms of if there's been any major shift from high-level plans. A summary of any sort of high-level key challenges and successes that we've experienced throughout the course of the financial year. And they've also included an update on our actual capacity and demand against our forecasted plans. In summary, there were no changes from income and expenditure, apart from the incorporation of the additional disabled facilities grant that was awarded partway through last financial year. That came down as a late addition, so was added into the Better Care Fund pool as a late addition. So that has been incorporated as part of the pool now going forward. In terms of our metrics performance, unfortunately, due to timing of year-end statutory returns and when the Better Care Fund report is needed, we didn't have full year reporting available for many of the metrics at this time. However, we have had to work on estimated forecasts. For many areas, we have seen an increase in improved performance across most areas against the national metrics, with the exception of continued challenges around avoidable admissions and falls admissions. But other areas, we have seen a continued improvement in both residential admissions, reablement, and also discharge to normal place of residence, with many of them being very close to being on track to meet target. But like I said, we didn't have the final formal reporting statistics at the time of reporting. In terms of capacity and demand and our actual capacity and demand against the forecasted plans that were submitted, they very much came in line with what we forecasted, which was very reassuring. We saw a slightly different trend in terms of reablement and intermediate care. Actual demand was slightly less than forecast in relation to hospital demand, but it was slightly higher against our community demand, which just indicated that we're doing slightly more in terms of step up, which is a good thing. And pathway 2 and pathway 3 capacity and demand, we revised those plans in Q3 and around November. Once those plans were refreshed, what we saw was the actual demand very much matched those refreshed plans. We also saw that actual demand for our community urgent community response service was slightly higher than forecast in a number of peak months. Just in final summary, we were asked to just submit a number of key successes and challenges, and just on reflection throughout the year, just in terms of successes, I just wanted to highlight that we have managed to sort of commission a new integrated and slightly innovative approach to high impact users. So this model was very much a partnership approach, which is being the ICB is using Better Care Fund funds to commission the Cambridgeshire County Council Community Services to deliver that as a community approach to supporting high intensive users who frequently attend the emergency department, to offer a more holistic approach to providing support to prevent and reduce those attendances. That is currently being implemented at the moment, that model. I think the other key success is the successful completion of the BCF evaluation, which we undertook and was recently completed around sort of April, May time. And Susan indicated earlier, we did have a very detailed and good discussion in the development session this morning. And as part of that, the key recommendations and findings of the BCF evaluation were fed back, and they will be used to inform future planning for future rounds of Better Care Fund as we go forward, particularly 25-26 planning onwards. And I think we just need to reflect, though, we do continue to have a number of challenges in the system, including the financial and workforce challenges and the pressures that we face around that, as well as we highlighted perhaps a growing disconnect that we do see as a result of some of the national condition metrics being very much focused on, for the BCF perspective, being focused on things which are a bit more longer term in nature, opposed to looking at more shorter term drivers, and seeing a bit of that sort of disconnect between actually wanting to do more around community-based prevention rather than some of the national drivers coming down being a bit more short-term nature. And that dichotomy really. I'll finish there and then I'll take any questions.
Do I see any hands up? Richard Howitt, thank you.
Just to say, I think it'd be helpful if we formally welcomed and very positively endorsed the recommendations of the Better Care Fund evaluation. I fully acknowledge I was a bit sceptical of it in advance, but we had a very good consultation with the people who were doing it in our last cycle of meetings. And although I think a lot in there is stuff that we want to do anyway, really, that doesn't matter because it's a very useful framework. So I hope that it's up to you to choose the right wording, but that we can do something that shows that we endorse the recommendations in the evaluation report.
Thank you for that. Any other contributions? No. Well, on that note, may I ask the board for its endorsement of the recommendations? Thank you. Thank you. Thank you very much, Caroline. I'm going to come right back to you in a second. Okay, we are now, the next item is the Better Care Fund 2024-25. And I guess the advantage here is that this is work in progress, and bearing in mind our discussion this morning, perhaps in your presentation, you could bring in some of our sort of reflect our discussion and in terms of opportunities here for action, new action. Thanks.
Yeah, thanks, Susan. I'll start off and then I'll bring Lisa and Sandra in if there's any additional points they want to add. So just to clarify, this relates to the refresh of current year Better Care Fund plans. So this is for 24-25. I think we do have some larger opportunities for next year's future planning cycles, which I'll reflect on a little bit in a moment. Where we did planning for Better Care Fund last year, it was actually a 2-year planning cycle. So we do actually have an existing BCF plan in place, which covers 2023 through to 2025. So there was not a requirement to submit a full BCF plan this financial year. But what we did need to do was we needed to submit refreshed plans. So there were a number of areas where we needed to do a light touch refresh around resubmitting capacity and demand plans across certain areas, a confirmation of our previously submitted income and expenditure plans, and also setting stretch targets in relation to our key performance metrics. So that is, they were the key areas. Essentially, there was no need to resubmit a formal narrative, etc., and we weren't making any substantial changes. Just to touch on what that meant in terms of submission, and the full planning template is attached as an appendix, which is obviously available to review. But just in summary, in terms of the capacity and demand plans, they very much cover both capacity and demand for hospital and community settings. And what we did to review those was we reviewed our actual demand across 2023-24, and we applied a 1.8% growth in areas where we expected demand to increase. And that's pretty much the model that has been applied in across the board. There is some more detailed system work that is being undertaken to look at capacity and demand at a system-wide level. For instance, there's Pathway 1 review work around reablement and intermediate care. However, that work and the timelines around that did not align with the BCF submission. So we had to work on a slightly different model to align with the NHS England timelines. Based on the developed plans, we don't have any areas of significant gaps in capacity to meet our forecast demand. So there aren't any highlighted areas where we believe we have any significant issues highlighted in those submitted plans. In terms of the performance metrics, we are required, to refresh our targets, and we're required to submit what they would describe as stretch targets. The metrics have largely stayed the same from a national metrics perspective, with the exception of one of the metrics has been removed. So what we refer to as the 91-day metric, which relates to the percentage of people aged 65 and over who are still at home 91 days after discharge from hospital, to reablement or rehabilitation. That has been removed because a new metric is due to be introduced at some point. That is still being sorted out at a national level. So we're still waiting on that. But at the point that that has been resolved nationally, we would expect that to come into the BCF national metrics and conditions at some point. The report outlines the metrics and what they look like. I think for many areas, we are sort of very much recognise that we have got kind of close to, or in some areas we haven't delivered target, but we also recognise that we are fighting against a growing demand and a growing and ageing population. So for many areas, we have looked at trying to maintain the level of performance, recognising that actually a maintenance represents a stretch target, in the sense that we're actually sort of fighting the growing demand in many cases. And in some areas where we have performed well, such as discharge to usual place of residence, we have stretched that target slightly further to reflect that. The income and just moving on to income and expenditure plans, there is a breakdown in terms of what that looks like. And you see that there is a slight increase in investment, both in the what we call the NHS minimum contribution and also in the discharge fund allocation. The report also outlines where that increase is being invested into. In terms of the NHS minimum contribution, that is largely being applied across contractual uplifts and inflation, and further investment in terms of urgent community response wraparound care and voluntary sector and mental health advocacy and tech from an ICB perspective. And from a local authority perspective, it's being invested in areas to ensure that we have sufficient residential and nursing home provision to ensure we have capacity to meet increasing demand. The ICB and local authority discharge funding and the increase in that funding is being invested to increase capacity across Pathway 1 and across reablement, social care discharge capacity, as well as funding the transfer of care hub, investment in a single point of access for voluntary support, and a number of other initiatives around supporting discharge. I will largely probably stop there. In terms of probably the other bit that I just wanted to reflect on, is just Susan said, is just in relation to future plans. So we will obviously be looking at some point 25-26 planning, and just reflecting on the fact that we have had the evaluation and the recommendations from that and the session this morning. I think we have definitely got some opportunities that we would want to be ensuring that we bring into future plans, and 25-26 planning is very much where we have that opportunity. Just to reflect quickly on where I think some of those are, is very much around how we start to move more to prevention and early intervention, how we can look at some of the investment areas that we've got and how we can move that to do more upstream, and how we can do prevention more holistically across the system, and how we really embed integration at a place-based level, and what that looks like going forward across health and social care, and particularly aligning that with some of the work that's coming through in terms of the new care models. So I think there's quite a lot of work that we want to look at over the coming months around what that starts to look like, what our vision really is, and having a really clear vision around how that looks and how we can work much more closely at a local level, and make best use of those resources locally, and certainly working much more closely with district partners and combined authority, and thinking about some of the changes that we'll have coming down with the new government. So I'll stop there and take questions. Sorry. Sandra, Lisa, did you have anything additional?
So you covered the bit on the capacity and demand, which I was going to bring up, and how we're working with HIP on that, about future sustainability on that side. And just reflecting really on this morning and that prevention side, I think for the admission avoidance metric, that is certainly an area which the prevention side will feed into. We do see early signs of the work that has started within the Peterborough area and reduced admissions in that area in certain conditions. But it's also about providing that care closer to home and sort of avoiding those hospital admissions. So that's really...
Thank you. So from a Peterborough perspective, I just wanted to raise a couple of areas around the falls. So we didn't hit the target last year. There's been a lot of work on the falls prevention strategy that has enabled us to consider that the target, we should be better placed to achieve that this year. Residential admissions, we did have a couple of spikes last year, but we have set a stretch target this year, and we have overall seen a reduction in numbers, but an increase in costs over and above inflation, so the uplift inflation. So I think that's worth bearing in mind, because there are pressures, financial pressures around that, even though numbers are reducing and we're doing Home First at a better rate. And I think specifically around the Adult Social Care Discharge Fund, which is included in the Better Care Fund, which ends in March next year. There's been a lot of value from that fund in respect of reablement and reablement in the community specifically, but also some of the areas which we know in Peterborough there are significant issues with, and that's people with learning disabilities having the appropriate accommodation, and people with mental health having rehabilitative pathways suited for them, and that is a focus for us this year.
Thank you. I see Nick Johnson and then Stuart Farrell. Thanks.
Yeah, thank you. It's obviously on the back of the discussion that we all had earlier on, and I think I've sort of going through the papers reminded me. With regard to the Better Care Fund, the first question I have is the performance metrics. I think I've heard you say these are national performance metrics, but are they the only performance metrics that the Better Care Fund is based on? And if I then go on, because my argument would be is that we spent a lot of time this morning talking about a new care model, but obviously a lot of those performance metrics are quite specific in certain, I would argue, in certain age groups. And that leads me to another question. When we talk about avoidable admissions, that piques my interest, trying to understand what the definition of avoidable admissions are. An avoidable admission is for a 2-year-old who swallowed paracetamol accidentally at home is, probably better care at home, as opposed to an avoidable admission of somebody who's maybe in an older age group. So it's the thing about breaking that down and trying to understand it a bit more. I don't know if that's part of the report, or maybe for me to go away and understand, but my biggest frustration leading to just hearing about the results is that I know I just spent 2 hours talking about a new care model, and if we're talking about trying to access money for the Better Care Fund, but that's all we're ever going to be measured on, then I'm not quite sure what I was talking about earlier on.
No, they're really good questions, Nick. So from a national perspective, they are nationally set metrics that we are measured on and our performance is tracked against. I'll answer first your question about avoidable admissions. So it is a very specific metric, and I might pass on to Sandra at this point, because it's and I've just called it avoidable admissions, but it's actually avoidable admissions for ambulatory conditions, which is a specific set of conditions, I believe, and Sandra will probably explain that, and then I'll come back to you on your other points.
It is, yeah. It's 10 long-term conditions which are termed as ambulatory care conditions. It is a rate per 100,000 population it's measured on, and it is all age. So you do look at things, and for children, particularly, you will see sort of admissions for children quite high in diabetes, and then the other one is epilepsy. So it's that sort of thing. And then sort of for adults, you've got angina, anemia, hypertension, heart failure. So it's all those sort of conditions.
Nick, there is in the HIP report, the BCF report, there is a slide that sets out those conditions in detail, and details for Peterborough and Cambridgeshire, the numbers that we achieved.
So just picking back up, so I think it's fair to say that there are some parameters that we have to work within in terms of the BCF funding. We don't have complete freedom in terms of what it can be spent on, so for instance, it can only be spent on adults. It's an adults funding pot. We can't spend it on children's, for instance. It's to fund health and social care, and there are different funding streams which come down through the Better Care Fund. We have certain minimum amounts, for instance, that have to pass to social care, and health have certain elements. We have, for instance, they introduced the sorry, forgot my words, and the discharge fund the end of the year before last. So that is a chunk of money that flows down through the BCF. That's one of the funding streams that has very specific conditions around it. So that has to be spent on supporting hospital discharges, for instance. We have an improved Better Care Fund funding stream in there, which has to be spent on supporting adult social care pressures, supporting the flow of pressures from the NHS, or supporting the wider social care market, for instance. And then we have the core Better Care Fund, where we have maybe, which is the old money. It has maybe less stringent conditions, but then there are expectations around that about areas that it does support. So because of where it was tied to in terms of it being old money, so there is expectations that that supports what they call the protection of social care, that it supports carers, that it supports reablement services. So we do have quite a lot of sort of conditions and boundaries that we have to work within, but that doesn't mean, that still gives us flexibility, but it's not a a complete, we can spend it on absolutely anything, I'm afraid.
Nick, since we're going to, I'm sure, ask you to exert your influence outside this room.
It's
please
just
come
to
back.
say, obviously, we've had a lot of chat about trying to introduce a new care model. And I'm just sitting here thinking, I can't see how any new care model could be implemented with with the greatest respect, you've educated me, with the amount of restriction in how the money, even if there is, it's just recycled money and we haven't even got that much. It concerns me as trying to think back on what we've done this morning.
Yeah, I think probably just one point to make, which I think is just really important, is just to remember is the Better Care Fund is really just one funding stream, though, within the system. And although it is, it is a lot of money, it is nowhere near as much money as we have in the whole system. So, you know, that we have, you know, there is a lot more money in the system. We have to look at it as a part of a system pot of money that we use to fund what we want to deliver. And I think that's what we need to remember.
Well, it's good to know.
Thank you. I'm just mindful of the time, but we do have 3 more speakers on this. If I could ask you each to be concise. First to Stuart Francis.
Thank you, Chair. Very concise. I'm just very pleased to see the investing in innovation and co-production involving local people and frontline staff. That's fantastic. And also the fact that that's communicated through place and neighbourhoods as well. So your point on page 18 scored very highly with me. Thank you.
Oops, thanks. I turn next to my colleague, Councillor Shabina Qayyum, and I'm also remiss because I had intended at the start of the meeting to welcome you to your first meeting as a new councillor for Peterborough and co-chair of this group. And so welcome, and over to you.
Thank you very much, Susan. Thank you very much for the report. My question is in relation to data regarding failed discharges. Is that relevant to this report? Is that something that you would take into consideration? And would you measure it against the outcomes in the report that you've just presented to us? Thank you.
So failed discharges is considered through the discharge work stream and the work that's done by the reablement teams and community teams, but it isn't actually taken into account as part of the metric for this report.
Thank you. And then Councillor Richard Howitt.
Caroline said it, but I'd underline it. We shouldn't be constrained by the Better Care Fund alone. It is only one part of the funding. Really, the recommendations are for the whole system and for all of our funding. So don't you or anyone else be put off by that. I think this has been a really well-informed discussion.
Thank you for that. Any other comments? No. Okay. Yes, could I thank our officers for this report, and the Health and Wellbeing Board ICP is asked to, let's see, I'm on the wrong page. Well, endorse, note, accept the report. Could I have your agreement, please? Thank you. Okay. Thanks. And we move next to the governance update. This is item 5, and Martin Whelan is going to present this. Thank you.
Thank you, Chair. So this is hopefully a very brief report. Obviously, the Health and Wellbeing Board is required to have both directors of public health as members of the board. However, because it's hardwired into both the 2 local authority constitutions, there just needs to be an acknowledgement from this meeting that you're happy for that change to be made. And then the 2 monitoring officers are then able to action that change, but there needed to be it needs to be recorded here first, was the advice from the local authority governance colleagues. Happy to take any questions, but I think it's self-explanatory.
Thanks. I think that's a true formality. Oh, sorry. Did anybody have their hand up? Not you, Liz, no. Okay. Thank you, Martin. That's great. Then we move to the agenda plan. Martin, would you like to present that? And then we'll have some comments.
I'll take the actual agenda plan as read, but it's just the normal opportunity for any suggestions for future items, either now or via the normal channels.
Okay, I think I'll just reiterate what I tried to express at the start of the meeting is that we really have some work to do on our agenda plan to move from analysis to action. And I think we do have a chair's briefing next week when we'll reflect on that, but we will be, I'm sure, calling on all of you around the table for your input. So if that's all right. Yeah. And yeah, other channels open all the time. And then we move to any other business, and we have an exciting notification of AOB from Stuart Francis. Thanks.
Yes, just one brief thing, Chair. We're getting some concerns expressed to us about the Dementia Resource Centre in Peterborough and its budget being cut by half from 279,000 to 137,000. We're wondering whether this is likely to rebound on the rest of the health system in terms of primary care and acute care. And I guess the point of the ICP is to ensure the patient ball isn't bouncing between two organisations, between NHS and local government. But given the rise in dementia, and that this was one of only two centres in the country, the other one I think is in Scotland, we are fielding some concerns about that.
Thank you for that. At the risk of, yeah, as you say, you don't want to be bounced around. I've got Louis and Val here. We're probably best placed, I think. Shabina, sorry.
Sorry, thank you, Stuart, for raising that. I'm currently involved as the cabinet member who oversees this resource. And I had a meeting yesterday with our adult social care director, as well as the director for commissioning in this regard. We're undertaking active interaction with the Alzheimer's Society. The situation is slightly complex in that the asset from which the Dementia Resource Centre was running out of has been sold, and an alternative provision is being looked at this moment in time, the terms of which are going to be confirmed. And you're absolutely right to bring up the point of whether there will be a rebound effect into other sectors of either primary care or even secondary care for that matter. But we are drawing up a brief of how the remodeled version will look, although we're not looking to reinvent, but definitely remodel. And that will be in active consultation with the service users, their carers, and the Alzheimer's Society. And what we've also pledged on is regular communication as well. So I hope at this moment in time that offers you some reassurance, but it certainly is a concern of ours. And it's one of the things that was stipulated to salvage because it was recognised as a critical service, as opposed to shelving the funding completely, because we recognise that the implications of it rebounding into other sectors of the NHS would be detrimental. So we've looked into that aspect already.
Well, I just hope that the service continues after all those discussions. Thank you.
Thank you for bringing that to our attention. And Shabina, thank you for your contribution. Richard, another AOB?
Wasn't actually, it was on future agenda plan B. I didn't manage to catch your eye. Sorry about that. I think we should thank Val for her note about examples from other authorities, which are essentially about political decentralisation and where health has perhaps got a greater role, vis-a-vis, for example, with the equivalent of our combined authority. And I think that's interesting and useful, but I don't think it's wholly what we were trying to get at. What we were trying to get at in asking for that was to try and look at how the ICP aspect of the governance is working in other areas. You know, if we weren't a committee in common, which I strongly want us to be and very proud of, don't get me wrong, anybody, But if we didn't have a committee in common and the ICP was meeting, who would be there and what would they be talking about? Because at the moment, the value added of having the committee in common isn't fully transparent to me, and I think to many people from what we saw in the previous feedback. And I think we're missing a trick here. And that's not just about having the North and South people here at the table or not at the table, but that's a structural solution. It's also about how we really are building partnership into our governance. And so I would like some further work to be done on that, and for us to be part of a future report back at this meeting, because I genuinely think we're not doing justice to the ICP element of what we're doing.
Thank you very much for that. I personally would agree, and we will take that to our agenda planning. Let's see, any other comments? No? I think that brings us to the end of this meeting, and I really would like to thank all of you for coming this morning to the development session and for the fantastic open discussion, and then also for staying even longer for our formal business. And I look forward to seeing you next time. Our next meeting is on the 11th of October. And meeting is closed. Thank you.